Let's jump right into this explainer. We're looking at a massive medical blind spot today, one that literally turns preventable emergencies into fatal tragedies. Based on an incredibly detailed legal and medical analysis from Palace Law, we're dissecting, no pun intended, the misdiagnosis of aortic dissections. It is a fascinating, but honestly terrifying look at what happens when the chaos of a fast-paced ER crashes head-on into cognitive bias.
So picture this for a second. You seek help for this excruciating, totally out-of-the-blue medical event, the kind of pain that literally drops you to your knees. But instead of a full workup, you're briefly checked out, told you're fine, and sent packing with some antacids for gastric reflux. You trust the docs, right? You head home, and just hours later, the result is absolutely catastrophic. Sadly, this exact nightmare plays out way too often in emergency rooms, and today, we're breaking down exactly why.
When patients describe an aortic dissection, they don't say it's a dull ache. They use really visceral words: tearing, ripping, thunderclap. It's not that heavy pressure you might associate with a standard heart attack. It is hyper-acute. It maxes out on the agony scale the very second it starts, feeling like a literal physical tear right in your chest, your upper back, or right between the shoulder blades.
Section 1. A catastrophic medical emergency. To truly grasp why missing this diagnosis is so devastating, we've got to look at what's actually happening under the hood.
Okay, so this condition is just sheer mechanical violence. The aorta, as you know, is your body's main blood vessel. When high pressure or tissue weakness causes a tear in that innermost lining, the tunica intima, blood pumping directly from the heart violently forces its way inside. It actively, physically strips the delicate structural layers of the arterial wall apart, creating this unnatural secondary channel called a false lumen. It is a massive structural failure happening in real time.
Doctors use the Stanford classification system to figure out the immediate game plan. Stanford type A, that's a tear in the ascending aorta, right up near the heart. This is a drop-everything immediate surgical emergency. It can cause a stroke or bleed right into the sac around the heart. Now, Stanford type B involves the descending aorta. It's usually managed in the ICU to aggressively tank the blood pressure. But make no mistake, it is a highly volatile crisis that can just abruptly cut off blood flow to your kidneys, your intestines, or your spinal cord.
And here's where the terrifying ticking clock comes in. Look at these mortality rates. For an untreated acute type A dissection, the chance of dying jumps by 1 to 2% every single hour. Within 24 hours, about a third of patients won't make it. Hit the 48-hour mark, that number climbs to nearly 50%. The window to step in and save a life is unbelievably now, which makes getting that diagnosis right away literally a matter of life and death.
Section 2. Missed signs and biases. So how on earth do highly trained ER docs miss something this severe, especially when it comes with classic, textbook red flags?
Well, a patient usually walks in presenting with these can't-miss indicators. We already mentioned that sudden thunderclap pain, right? But another massive clue is migrating pain. As the blood forces its way down the aorta, the pain literally travels from the chest down into the abdomen or even the legs. You might also see pulse and blood pressure asymmetry, like a strong pulse in one arm and barely anything in the other, because that tearing is cutting off branching vessels. Completely missing these glaring textbook red flags, that is often the core of a medical malpractice case.
And those missed symptoms feed directly into a deadly cognitive trap: anchor bias. ERs are chaotic, they're fast, and triage is built for the most common culprits. Someone comes in with chest pain and bam, the ER instantly anchors to the standard heart attack protocol. If the tests like troponin levels don't clearly scream heart attack, the doctors often just settle. Even if troponin is slightly elevated, they might write it off and anchor to a low-risk, easy explanation like GERD. They might even hand over a GI cocktail with antacids. If the patient feels even a tiny bit better, the doctor feels totally justified in saying, yep, that's just reflux.
Now you're probably thinking, don't they do x-rays? They do, but relying on a basic 2D chest x-ray to rule out an aortic dissection is a huge, dangerous mistake. Those x-rays fail to catch the condition in roughly 36% of patients, more than a third. That primary visual clue doctors are hunting for, a widened mediastinum, is just completely absent in over a third of confirmed type A cases.
To actually see what's happening, you need the gold standard, a CT angiogram, or CTA, of the chest and abdomen. They shoot in some contrast dye, and it completely lights up the blood flow. That tear becomes instantly visible to a radiologist. It takes less than 10 minutes, guys. 10 minutes. It's non-invasive, it's everywhere. Failing to order a CTA when a patient is sitting there with sudden migrating pain, That is a massive deviation from the standard of care.
And making matters worse is demographic bias. Doctors sometimes talk themselves right out of running life-saving tests just because the patient doesn't fit the classic textbook mold. You know, the older guy with a history of high blood pressure. When younger patients or women without hypertension show up with these exact agonizing symptoms, they're disproportionately brushed off. Young women are constantly told they're just having a panic attack, hyperventilating, or maybe pulled a muscle at the gym. It's incredibly frustrating.
Section 3. The deadly cost of delay. When you stack up all these biases, and the ER falls back on that easy reflux excuse, the outcome is almost universally fatal.
The sequence of events for a discharged patient is literally a death sentence. Hours 0 to 2, they're sent out the door with antacids or anxiety meds. Hours 2 to 24, they go home to lay down, but their blood pressure is completely unchecked. Every single heartbeat is just dynamically hammering against that torn, weakened arterial wall. Eventually, it reaches a breaking point. The outermost layer, the tunica adventitia, just can't hold back the pressure anymore. The final result is a catastrophic rupture, massive internal bleeding, and sudden death.
Section 4. Seeking truth and accountability. For the families left behind, it's unimaginably traumatic. One minute a doctor is saying their loved one is fine, and the next, they're gone. That shock and grief very quickly pivots into a desperate search for answers.
The analysis from Paulus Law lays out the 4 rigorous legal pillars needed to actually build a medical malpractice or wrongful death claim here. First, duty of care, simply proving the patient was treated in that ER. Second, breach of duty, showing a competent doctor would have absolutely ordered that definitive CTA scan instead of writing it off as heartburn. Third, causation, bringing in independent medical experts to prove that the missed scan directly caused the death and that prompt surgery would have saved them. And finally, damages, putting a number on the profound human and financial loss that family is now facing.
But getting to the truth is an uphill battle. Hospitals aren't exactly lining up to voluntarily admit they made a massive diagnostic blunder. Instead, they'll usually try to frame the death as an unforeseeable, sudden cardiac event just to shield themselves from liability. Institutions protect themselves first, so getting clarity means you have to look right past whatever initial excuse the hospital feeds you.
And that is exactly why getting your hands on a clear, unredacted copy of the complete medical records, the ER triage notes, and the actual imaging files is step 1. Navigating that maze, usually with a seasoned attorney right there with you, is how families actually nail down the timeline. It lets independent experts cut through all that dense medical jargon and pinpoint the exact moment the standard of care went out the window.
Which brings us to a really provocative final thought. If a simple, non-invasive 10-minute CT scan is literally the definitive difference between life and death, why on earth is our medical system still settling for the reflux excuse? It really highlights why patient advocacy is absolutely crucial, and why we have to relentlessly question the easy, convenient answers we're given in the emergency room. Thanks for tuning into this explainer. Stay curious, stay informed, and always ask questions.